Breech is actually a longitudinal lie. Unlike vertex, where the podalic pole is in the lower pole of the uterus, it is breech presentation. Most commonest is frank breech or extended breech, where the hip is flexed and the knees are extended. Here see the legs are splinting on either side of the head. This is frank breech, which is the commonest one. Next, we have got a flexed breech or a complete breech, where the attitude of universal flexion is maintained, so the hip is flexed as well as the knee is also flexed. Then we have various forms of extension, like a footling, where the baby just stands inside the mother's womb, or a knee presentation, where the knee is flexed and the hip is extended. Coming to the palpation, here it's a longitudinal lie in inspection. In your fundal grip, in a frank breech or extended breech, head is in the midline. The limbs are splinting the head on either side, so the head is not that freely ballotable as in a flexed breech. In a flexed breech, you find the head towards one side of the midline, head is freely ballotable and irregular. In your pelvic grip, it is irregular presentation that is felt because a flexed breech is not as compact as an extended breech. Lie is longitudinal, denominator is the sacrum, engaging diameter is the bitrochanteric diameter. So based upon where the sacrum is, you have got a left sacroanterior, right sacroanterior, right sacroposterior and a left sacroposterior. Compared to flexed breech, extended breech is a better one for vaginal delivery, because you find because of the compact breech, it enters the pelvis and the chance of premature rupture of membrane and cord prolapse is just a bit higher than that of a vertex presentation. In vertex it is 0.4% and in extended breech it is 0.5%. So that is why extended breech is good for vaginal delivery. In flexed breech, because of the irregular fitting presenting part, premature rupture of the membrane and cord prolapse can occur, and there is almost a 6% chance of cord prolapse in flexed breech, whereas in footling breech it is almost 20%, 15 to 20%. That is why footling breech we never keep for vaginal delivery, we do a cesarean section. Similarly, a flexed breech with a rupture of membrane, we don't augment labor also because of the high incidence of cord prolapse. There are certain factors that favors a breech presentation, like in prematures you find the broad head tends to occupy the fundus of the head. Similarly, congenital anomalies of the fetus like hydrocephalus, trisomies and all, you find breech presentation more common. Certain maternal factors that favor breech presentation is anomalous Mullerian tract like a septum, subseptum, bicornuate and all, you find the incidence of breech is more common. Coming to the mechanism of labor, in commonest is the LSA, so the bitrochanteric enters in the right oblique diameter. Delivery of mechanism of delivery of the breech, it is in three parts. First is the delivery of the breech, second is the delivery of the shoulders, and in breech we say the head as the after coming head, and that is, then there is a mechanism of delivery for the after coming head. So first the cardinal movement is descent with compaction compared to the descent with flexion in a vertex presentation. Even if the sacrum is posterior also, there is always an anterior buttock, so there is only a 45-degree rotation in internal rotation of the breech is always a short rotation only. There is no entity of long rotation, just as in an occipito-posterior. Now the second stage is imminent. Next movement after internal rotation is lateroflexion, where the spine is flexed, undergoes a lateral flexion, and then the movement is breech climbing the perineum. Just like your crowning, you have the breech climbing the perineum, and she is ready for an assisted breech delivery. Coming to the delivery of the shoulders, shoulders also bitrochanteric diameter enters in the same oblique diameter, undergoes internal rotation, anterior shoulder delivered first and then followed with the delivery of the posterior shoulder. In the aftercoming head, it is a deflexed head. So the engaging diameter is occipitofrontal or suboccipitofrontal or occipitofrontal. It enters in the opposite oblique diameter, undergoes internal rotation, and by a process of flexion the head comes out. Once you know that she is in the second stage of labor, always do a pervaginal examination and make sure that there is no rim of cervix anywhere around, and the cervix should be fully dilated. You find the breech climbing the perineum, you have to bring her to the edge of the table. You can do a vertex delivery by the woman lying in the middle of the cot, whereas a breech delivery you have to bring her to the edge of the cot, so that at certain stage you have to hang the breech on its own weight. So once she is in second stage, the anal aperture has opened, the introitus has gaped, perineum has thinned out. Put a liberal episiotomy, because delivery of breech is in 3 parts. So after having put the liberal episiotomy, if you are well versed in a pudendal block, you can give even a pudendal block where you palpate the ischial spines and pierce 1 finger breadth medial to the ischial spine. You pierce the ischiospinous ligament and infiltrate with 1% lignocaine 5 cc on either side. After having made a liberal episiotomy, by watchful expectancy, you wait for the breech to get delivered. There is no difficulty in the delivery of a flexed breech at this stage, because usually the limbs will slip out. Whereas in an extended breech, you may have to put your 2 fingers into the crural fold and by gentle traction just release out the legs. Both sides you have to release out the legs. Now the baby is hanging on its weight but gently supported by the obstetrician, and see that the baby's back is facing. Slowly by contraction you find the abdomen descends out. Once the breech has delivered, the baby is covered with a towel to prevent premature attempt of respiration. A loop of cord is pulled and kept by the side of the baby. But we don't much rely on the cord pulsation at that time, because at some stage the shoulder will be now at the level of the brim. So slowly with contraction the breech will be descending down, and once the tip of the scapula is seen or the posterior axillary fold is seen, the baby is caught hold in the femoropelvic grip. You don't catch hold on to the abdomen, because by giving traction you might produce a visceral injury. So by the femoropelvic grip, once the breech descends down, once the posterior axillary fold is seen, you do the Lausset's maneuver in an assisted breech delivery. The baby's back is turned either to the right or to the left, and now you find the anterior arm just slips out. If there is difficulty in delivery of the posterior arm, the back is turned to the opposite direction and the posterior shoulder is made an anterior shoulder, and the anterior shoulder arm is delivered out. Again, you face the back of the baby should face the obstetrician and gently hold the baby. With uterine contraction, slowly the head descends down, and once the hairline is seen, the baby is caught hold, both legs are caught hold with the right arm of the obstetrician, and the baby is just carried an arc over the mother's abdomen to facilitate flexion. At the same time, an assistant will be giving suprapubic pressure also, so that the subocciput hitch against the pubic symphysis. Now the breech delivery is completed. The delivery of the breech is in 3 stages: the delivery of the breech, delivery of the shoulders, and delivery of the aftercoming head. That is why the high perinatal mortality in breech. You have a wide range of mortality from 3 to 20%. That is because careful selection of the patient for keeping for vaginal delivery, as well as the skill of the obstetrician, all accounts in bringing down the perinatal mortality. So the indication for cesarean in a breech, other than other obstetric indication like placenta previa, previous cesarean and all, A breech with a bigger baby more than 3.5 kg where you anticipate a fetopelvic disproportion is kept for a cesarean section. Normally in a cephalic you have a Munroe-Muller method of estimation of cephalopelvic disproportion, whereas in breech you don't have such an entity. So the pelvis should be good in all planes of the pelvis, as well as the fetal size should be less than 3.5 kg. Again, other indication is an extended head, or called a stargazing head, where the head is extended. You don't keep it for a vaginal delivery. If the hairline is not properly seen, you go by the technique of Mauricio-Smellie-Weeds method. In that, the baby rests on the left arm of the obstetrician and a malar pressure is given at the malar eminence, or it is called a jaw flexion, and by good uterine contraction slowly the head descends and shoulder traction is simultaneously applied so that the two fingers are on either shoulder blade, and then the baby is carried a arc over the mother's abdomen. This is Mauricio-Smellie-Weeds method, which is a jaw flexion shoulder traction method. Ideal for the delivery of the aftercoming head is the application of a long Piper's forceps. Here the baby is lifted up and enough space is created in the posterior quadrant of the pelvis. A cephalic application is applied and slowly the head is brought out. The advantage of this method is you produce an artificial molding by the application of the forceps, and you don't give traction at the nape of the neck, so vital structures are not injured and a controlled force is used. So ideal is forceps application for the aftercoming head if there is difficulty with your Marshall-Burns technique. In the antenatal management of breech delivery, we do the external cephalic version, because as all of us know, the perinatal mortality of breech has a wide range from 3 to 20%, because the delivery of breech is in 3 stages: delivery of the breech, delivery of the shoulders, and delivery of the aftercoming head. So external cephalic version, the word itself is self-explanatory. It is an external movement that we do to convert it to a cephalic presentation, hence called external cephalic version. It is usually done between 36 to 37 weeks, because normal spontaneous version might occur up to 36 weeks. The prerequisites for a external cephalic version to be successful is that flexed breech, the success is better. With multiparity, the success is better. With fair amount of liquor also, the success is better. The contraindications for external cephalic version is a scarred uterus, antepartum hemorrhage, placenta previa, any complicated breech like a preeclampsia with a breech, or an anomalous fetus. How we do the procedure is, actually we do a pre-procedure CTG, then we map the fetus by doing an ultrasound to know where the back of the fetus is. In external cephalic version, after having done a scan and noting which side the back is, the fetus is caught hold in the universal flexion attitude, and with the one hand the breech is disimpacted from the pelvic brim, and we turn towards the side of the back and make it as a cephalic presentation. Once it has rotated through 180 degree, automatically the head will come down because of the weight of the fetal head. So after a post-procedure CTG is also done, and a scan is done to ascertain whether it is in the cephalic position. The advantage of doing an external cephalic version is that if there is an abnormality of the pelvis in any one plane, we are doing a cesarean section, whereas if we are converted to a cephalic presentation, we can go ahead with the trial of labor even if there is an abnormality in one plane of the pelvis.